Good afternoon, everyone. I'm Lindsey Criswell, Vice Chancellor of Research. I'd like to welcome you to the fourth of a series of COVID-19 related research town halls sponsored by the Office of Research. Before we begin our program today, I would like to draw your attention to some guidance you will all be receiving over the next couple of days related to our plans for gradually increasing the amount of research being conducted here on site. All PIs will be provided guidance on determining which types of research can proceed and which types of personnel can be on site in this initial phase of increased research activities at the UCSF campus. Tomorrow, you will also be receiving important information about parking and transportation related to these plans. As you will hear, we will be requiring everyone on site to be screened each day for symptoms or risk factors related to COVID-19. And beginning on Monday, this next Monday, the campus will be adopting the same online tool that's been used by UCSF Health to perform the daily health screening of all employees and students. We will be providing you with instructions very soon. In addition, the San Francisco Department of Public Health has established requirements for face coverings and physical distancing. The campus will provide you with a reusable cloth face covering for each employee and student, but we recommend that you bring your own face covering from home to avoid delays here on campus. So you will be receiving other important details about these plans very soon, so please look out to messages from the Office of Research and other campus offices within the next few days. We are also planning a town hall for next week on the 20th in collaboration with the Academic Senate to address any questions and concerns you related to these important next steps that the campus is taking to begin resuming our research activities. So I'd now like to introduce David Erle, Director of UCSF CoLabs, who will be moderating today's town hall. Thank you so much, David.
Thank you, Lindsey. It's really exciting to hear that we're starting to make progress toward being able to restart some of our non-COVID-19 related research. And this reminds me, of course, about how remarkable it is that people have been making so much progress in doing COVID-19 related research in the face of all of these logistical challenges. So today we're going to hear three presentations. There, you can see them on your screen. The first is the Unidos and Salud COVID-19 Test and Respond study in the Mission District, and that'll be presented by Gabe Chamie and Carina Marquez. Then we're going to hear about performance testing of serologic assays from Jeff Whitman. And finally, we're going to hear about the Pregnancy Coronavirus Outcomes Registry or Priority Project and the Reproductive Health Equity and Birth Justice Corps from Monica McLemore. So again, without further ado, I'll get to our first project. This is the Unidos and Salud COVID-19 Test and Response study based in the Mission District. The work's going to be presented by two UCSF faculty members from the UCSF Department of Medicine's Division of HIV, ID, and Global Medicine at Zuckerberg San Francisco General Hospital. The two presenters are Gabe Chamie, who's an associate professor in residence, and Carina Marquez, who's an assistant professor and the associate director of equity at the UCSF Center for AIDS Research. Gabe?
Good afternoon, everyone, and thank you to the organizers for the opportunity to present this. Let me move into presenter mode. Hopefully everybody can see the screen. So it's a real pleasure and a privilege for us to present on behalf of a large study team. This did not take place, of course, as just a few people, but really with a large group. Shown here are co-investigators at UCSF, including my study co-lead Diane Havlier and Brian Greenhouse, and Carina Marquez, and I will be presenting on behalf of the group today. So I think, as we know, in terms of COVID-19 transmission at a community level, what we're seeing in the hospital and in clinics are really the tip of the pyramid. When we think about the ongoing transmission in community settings, we know that not everyone is symptomatic and that mild and asymptomatic infections may go unnoticed. So testing and responding to people in the community before they are hospitalized may reduce transmission and can accelerate epidemic control. Early on in the pandemic, testing was focused on symptomatic persons. So we sought for the study I'm about to share to understand COVID-19 transmission dynamics at the community level. The motivation for the COVID-19 test and response study, we know from our hospitalization data. Here's data shared courtesy of Vivek Jain and colleagues from San Francisco General Hospital, where 84% of hospitalized cases are among Latinx persons. So we know that the Latinx community and communities of color across the United States are disproportionately affected by COVID-19. We know that these disparities are persisting during shelter in place. And we know we need data to inform a community level response. Therefore, our objectives were really a three-pronged objectives: to reach, test, and respond. And by reach, this was informing and mobilizing a population that's not being reached adequately by current testing and care systems. From a testing perspective, we sought to determine active and prior COVID-19 infections by testing all people using swab and PCR and finger stick blood collection for antibody. And this is all people regardless of symptoms in a given community. In terms of the response prong, it was to evaluate a novel community-based test to care program. The results I'm sharing today, these are preliminary results of the PCR testing only. Antibody testing and molecular epidemiologic studies are in progress, and the goal is to follow this cohort over time as public health measures evolve and shelter in place is lifted. Just to give a brief orientation to where the census tract of the study is located, this is within the Mission District in San Francisco. Shown here is a map of population density, and this census tract in the Mission is the most population dense census tract in the Mission and the second most dense in San Francisco of all districts greater than 5,000 people. It has 4,087 adults over the age of 20, it's 58% Latinx, and 34% of residents have a household income less than $50,000 per year annually. In terms of partnerships that are at the foundation of the study and would not have been possible without all the groups shown here working together, are the Latino COVID-19 Task Force and Supervisor Hillary Ronan's office were critical in collaborating and in making this possible. The Office of Mayor Breed, the SF Department of Public Health, and critically San Francisco Parks and Rec and the school board in providing access to venues which we were in the community, which included 2 elementary schools, such as Flynn Elementary shown here, right against the census tract, Cesar Chavez, and then 2 parks within the census tract. And then of course UCSF, San Francisco General, the Chan Zuckerberg Biohub, where all the PCR testing was performed, and the clinical lab at UCSF. I also must mention that we recruited and trained 450 medical and community volunteers. There was really incredible outpouring of support and interest in the study and in the community's response to COVID-19 and understanding what's happening in terms of transmission dynamics. Shown here are several of our medical and community volunteers at Flynn Elementary, as well as the Latino COVID-19 Task Force at the study headquarters, which were the Brava Theater on 24th and the Mission, which was donated as space for this, for outreach and mobilization to the community. What are some of the things we learned through this project? First is that there is clearly high demand for testing in the community. In 4 days, the Unidos on Salud project increased San Francisco's total number of COVID-19 tests by 29%, with about 14,570 COVID tests performed before April 25th and 4,160 performed over 4 days of testing. Who did we reach for COVID-19 testing? In total, we tested 4,160, and residents and workers made up roughly just under 3,000 of this number. We expanded, given the demand on the last day of testing, to about a block or 2 outside of the catchment area, and 800 people came to test in that time period. And then we had about 400 others that were made up primarily of volunteers. Of those who tested, a little over half were male. 44% were Latinx, 38% white, 11% Asian Pacific Islander, 3% Black or African American, and 4% self-identified as other. And when we look at positivity within the census tract, overall, when we look at community members, which we classified as people who either live or people who live elsewhere but work in the community, these are the tracked workers, we see an overall positivity of 2.1%. This was 6.1% among tracked workers and 1.4% among tracked residents. And this compared to 1.4% positivity in the expanded area and less than, or roughly around 0.2%, that's a typo there, but in others. Some of the things that stuck out, and I'll go through these quickly, is that when we compare people who tested PCR positive to overall people who tested, the vast majority of those who were PCR positive, 90%, reported they cannot work from home during shelter in place and sustain their incomes. When we look at PCR positives versus the overall tested population, again, we see that the PCR positives were disproportionately male, disproportionately Latinx, at 44% there to Latinx in the tested population versus 95% of PCR positives. When we look at income, it was about a third or a little over a third of tested people had an income less than $50,000 per year compared to 89% of PCR positive persons. And when we look at household size, we see a greater proportion of people with a household size of 3 and up. We did not see an age distribution. Okay, I'm going to turn it over to my colleague, Carina Marquez, to pick it up from here. Thank you.
Thanks so much, Gabe. So I will be talking about some of the clinical features of the PCR positive patients and also talk about the care part of the test to care model. So one of the things we wanted to address in this project is, can we rely on symptoms for testing yield? We know that people can have detectable or transmittable virus when they're asymptomatic, pre-symptomatic, or when they have symptoms and mild symptoms. So in the study, we found that among the PCR positive people, 53% reported no symptoms. And of those who did not have symptoms, 33% reported cough, 17% reported muscle aches, 11% fevers, and I'll also add that 9% reported loss of taste or smell. Next slide. Great. So as mentioned, our study was not just about testing. It's really also about responding to positive test results and providing wraparound services for people who test positive. So what was the care model? Well, we're fortunate in San Francisco to have an outstanding public health department. And once a person tests positive, the DPH reaches out to the person, provides case and contact investigation services and linkages to isolation and quarantine hotels if needed. This is the usual care in San Francisco. And what we're evaluating in this project is providing additional supplementary services, especially to the most vulnerable populations. Self-isolation can create a considerable financial burden on people, and isolation is really challenging in crowded living environments. We need to be able to respond to these needs. And so our augmented support model included, a multidisciplinary hospital-based clinical team, which we call the CRT, and a community-based wellness team called the CWT. The CRT, which is our hospital-based team, was comprised of a multidisciplinary team. It had MDs, RNs, social workers, and was based here at San Francisco General Hospital. We made calls to disclosure calls, assess medical needs, symptoms, and also assess whether a person had a doctor. We also made regular wellness check-in calls and helped link people to care. In addition, we were able to refer households to the community wellness team. And the community wellness team is a fully community staffed and led team that provided education and supportive services for households to effectively self-isolate and quarantine. Next slide. So let me tell you a little bit about some of the early findings of the Test to Care program. So to date, the care team was able to reach and talk personally with 70 of the 73 PCR positive patients. And these 70 patients who we spoke to received their results within 48 to 72 hours. And those remaining 3 we're working with DPH to reach them. The majority of people who we talked to were not yet connected to primary care. 29 of the 70 people had a primary care doctor. And certainly an important objective of our response is to link people to primary care. And then on the right, the picture, you can see our isolation and care package. Delivered to the community members to support people in isolation and quarantine. We were able to deliver food, provide work letters, help facilitate referrals to hotels if needed. And what isn't pictured here, but is so central to all the support and is really the coaching and support that our community teams provided to the participants. Next slide. So what do these preliminary results tell us? Well, first, mass testing is possible with strong community partnerships. when it's community-led and when the community is front and center. Thousands of people came out for testing despite the vast majority of people being asymptomatic, and certainly the volunteerism and the leadership within the community was so inspiring and central to this success. Secondly, over 2% of persons tested who live or work in the Mission Census Tract were PCR positive, and this was 6 weeks into shelter in place. We saw that ongoing active infections are certainly not evenly distributed across the community, and over half of the infections are half of the people are asymptomatic at the time of testing. Additionally, low-wage Latinx community members who do not have the privilege, many of whom do not have the privilege to work from home during shelter in place, are disproportionately affected by COVID-19. And I will say that these inequities are stark and certainly a call to action to ensure that test and care reach the people who are bearing the largest toll of this epidemic. And thirdly, community testing in priority areas with a test to care intervention for vulnerable populations may accelerate epidemic control. And then my last note is that the success of this effort was certainly rooted in an integrated community, public health, government, and university partnership, and these were critical to making this happen. Next slide. So I'll just close with acknowledgements. We'd certainly like to thank the over the 400 volunteers, university groups, city officials, especially Supervisor Ronan's office, and especially the Latino Task Force, all of whom came together for this project. And we in the study team have been so inspired by the power of community and collective action that's here to address this epidemic. Thanks.
Great, thank you so much. That was a really informative presentation, quite a tour de force to put together a study like this on such an incredibly short time frame. I want to point out, I should have mentioned at the top that we are going to have time to take questions for each of the speakers today. We're going to take those the questions for our first two speakers now. So please go to the Q&A box. I see some of you are beginning to pose questions, and that's great. We'll have time to answer as many of those as possible. So let me start with the first question. Gabe and Carina, I'll let you decide who's better suited to answer these. The first question was really, why did you choose to restrict the study largely to this particular census tract?
Carina, do you want to take that one first? We'll go back and forth. Or you like, okay. A couple things. One is, as noted, we were interested in understanding community transmission. We were seeing both in the hospital that COVID-19 infections were disproportionately affecting within the patients that we see at San Francisco General, the Latinx population. That certainly made the mission an interest, but also we're interested in a urban population dense area, and this fit that criteria.
Great. Another question, how was this study funded, and was the testing funded differently than the care portion of the study?
Good question. So the funding came through both a mixture of unfunded efforts, so volunteer work, as you can see, which was a massive amount of volunteerism, thankfully. We are supported in part through a grant from PIBR and the UCSF grant funding, and support from the labs as well at UCSF. What was the other part of that question? I want to make sure I didn't miss it.
Was the care part of the study funded?
Yeah, so we also created a GoFundMe account that allowed us to use 100% of the funds raised from that online service, basically, to provide the community wellness team outreach, which included access to food, and there's donations as well from community members, including a grocery outlet in the Mission. So a lot of it, again, came through donations.
Great. We have a couple of questions from Homer Boucher, who asks, what proportion of people without symptoms went on to develop them, and what proportion of those with symptoms went on to worsen and need hospitalization?
Do you want me to answer that too, Carina, or would you like to go ahead?
I can speak to the hospitalization part. So of our the group of people who were PCR positive, only one person required hospitalization. That was pretty early on into the diagnosis. The majority of people who were asymptomatic remained asymptomatic, and we had a lot of people who had had mild symptoms also remained to have mild symptoms. I think we are working on tabulating the final numbers for those who sort of were pre-symptomatic and developed symptoms. So we certainly would like to share that once those are final.
Great. Here's an interesting question. Do you have any data on mask wearing for people who tested positive?
Do you mean history of mask wearing?
Yeah.
We asked, go ahead, Carina.
No, I mean, I think, the initial questionnaire for that people answer before they were tested, was meant to be pretty lean to get people in quickly, and we did not collect information on mask wearing at the testing day. It's certainly something that we are hoping to assess with our PCR positive patients in the question that we are exploring. I don't know if you have anything to add, Kate.
No, we did ask about ability to shelter in place, and I think that was one of the critical findings.
Mm-hmm.
But not specifically about wearing masks. We did provide masks, I will say, to everyone who came to test, if they didn't have one already, that they were wearing.
Yes, and also just to add that the community wellness team, when they talk to patients and ask sort of what do you need to help support your isolation quarantine, and mask was certainly something that people asked for quite a bit, and we were able to provide to the households. And people had a lot of questions about that.
Great. Peter Hunt from the Division of Experimental Medicine, I'm sure you know well, asks, what proportion of the household contacts of PCR positive primary cases were PCR positive? And do they have ongoing surveillance to assess, do you have ongoing surveillance to assess for transmission during home quarantine?
Carina, do you want to field that one? I can say that we have testing data from, and know where people live, so we have household data, but there is heterogeneity in proportion of household members. There's obviously varying household sizes, but heterogeneity in the number of household members that tested at our testing venue. But that is actively being explored, and certainly we recommended and are following up on all household members of PCR positives for testing. Hope to have more data on that in that regard.
Great. Maybe time for one or two more questions. Do you want to comment on how your data inform the return to work or return to school policy discussions that are very active now?
I think for one thing, our data show that people who are still working and are in essential jobs, I didn't comment on it here, but I'd seen a pre-question. When you look at the occupations of many of the PCR positives, you see a disproportionate number of people who are working in food services, continuing to provide food at grocery stores and other outlets that are really essential services, as well as other types of work like janitorial and cleaning work. Things that people are relying on as they're sheltering in place. Many of these are low-income people many of the PCR positives are low-income people who are still working. So I think some people, despite the shelter in place, have continued to work. And I think what that suggests is that people need access to testing, increased access to testing, and that people who have not been able to shelter in place really need to be accessing testing, right, or have testing brought to them and support if they need to self-isolate or quarantine. We're going to move forward.
Great.
I'll also add, we had a large proportion of people who are asymptomatic, and I think the need to be able to test asymptomatic people is going to be important as we move forward.
Agree wholeheartedly, yeah.
Great, and maybe a good final question to segue to the next talk. When are the which serologic tests are you using, and when are the results expected to be available?
We are starting with the Abbott assay, and our hope is to have results back within the next 2 weeks. And the plan is to take a series type approach and testing in series. So for those who test positive by the assay, the hope is to cross-validate with another antibody, so as to hopefully detect false positives or and validate the positives we do detect.
Great. So I think that's all we have time for, but that was terrific. Great talk and excellent answers. There are a lot of questions that we didn't have a chance to answer just now. If Gabe and Carina are so inclined, they can go to the Q&A box. We already have 28 questions. Some of them we handled, and they can type answers there, so you can keep an eye on that. Any question that we don't have a chance to answer now, we're going to collect and post on the website. We hope to have both a recording of this session and the answers to those questions available by the end of the week. So thanks again to Gabe and Carina. And now I'm going to introduce our next speaker. Our next speaker is Jeff Whitman. Jeff, if you could turn your video on and unmute yourself, that would be great. Jeff is a fellow in the Department of Pathology, and he's going to talk to us today about he and a larger group's work performance testing serologic assays. Jeff?
Great, thank you for that introduction, and thank you so much for the invitation to talk today. So I'm very pleased to talk about our recent work on a test performance evaluation of SARS-CoV-2 serological assays. And as you mentioned, this was a very large group, so these affiliations at the bottom are not mine, but really representative of the larger group that really came together to get this data and these results. First off, I have no conflicts of interest to declare, but I would like to say that we had a number of project funding sources as listed here. And I'd like to emphasize that this is a preliminary report of work and has not been peer reviewed yet. As far as aims and takeaways, we're probably gonna have a little bit more introduction here than, but I think that's really important because I really want to discuss the common serology testing modalities that are available for SARS-CoV-2 and how they perform, and then also provide insight into study design for generating these test performance characteristics. And I think that's really important to take away when you may read our results or you may read other studies' results or potentially what the manufacturer's test results are. So you just understand how these statistics are generated. And really, the information, answers and insight from serology testing are really going to come from a lot of different places. So we only really bring one thing to the table, but really the overlap of epidemiology, understanding of healthcare and public health systems, and the biology of disease is where all the answers and insights will be found. Why do we perform test performance evaluations? Well, one, it's really important to understand how these tests work, to understand their appropriate use and the interpretation of their results in different populations. So you want to know how a test works in terms of sensitivity and specificity, whether you are screening a population or maybe trying to use it for clinical diagnosis. It's really important to know how that test is performing in those situations. If you have a lot of confidence in your test performance evaluations, especially from larger studies or maybe multi-center studies, those may be very useful in crafting clinical and public health policies down the line. And lastly, I think it provides really good feedback to test developers who may not always get to see how their tests perform head-to-head or in potentially a larger specimen set than they had available to them. And I'd also like to point out that we are just one of many groups that are coming out with serological test performance evaluations. A couple have been put up on medRxiv that are evaluate lateral flows and ELISAs like us, but more are coming out every day that are also analyzing the higher throughput assays like Abbott and whatnot. So jumping into sort of an introduction to serology testing. The serology testing itself is used to detect antibody responses to SARS-CoV-2. And it's really seeing how the body is adapting to the and sensing the SARS-CoV-2 infection versus directly detecting the virus itself. Over time, these serological responses will increase, and that's expected as the body mounts this response. So what is currently emerging about the kinetics of seroconversion are that the antibody responses really get robust after 1 to 2 weeks. In regards to the overall principles of serology testing, I realize there are a lot of different modalities that may be used, but overall this is pretty much a general overview of what is happening. If you have a patient's blood sample and you add it to the assay, if preformed antibodies are present from that sample, indicative of previous exposure or infection, they will bind to SARS-CoV-2 antigens that are present on the kit. From there, you can add a secondary reagent, a secondary antibody to human antibodies. And they can be of different isotypes like IgG or IgM. And those secondary antibodies have a reporter that's conjugated to them. Oftentimes, it's an enzyme that turns over a substrate into a colored product. So here are two common forms of those serology tests. Here on the left, we see the enzyme-linked immunosorbent assay, or ELISA. And here you can see in the individual wells are that colorimetric product. Now these are objectively read by a spectrophotometer. So the value that you get is based off of how much color is produced, which is a function of how much antibody or affinity of that antibody is there. And from there, the cutoff of determining positive or negative is either set by the manufacturer or by the laboratory itself, evaluating a number of positives and negatives and assigning a cutoff that has the adequate sensitivity and specificity that you want. Another style of test that we evaluated were the immunochromatographic lateral flow assays. Now these are sort of what you would call point of care style tests. The antigen is placed on is put on a little test strip here. The sample is put in the well and it diffuses across the test strip. If those antibodies are present, they will bind to those antigens at that test strip. And what's different about these tests is that they are subjectively interpreted. So they're a qualitative assessment of just if any color is noted, the reader calls it positive or negative. And for our study specifically, to capture some components of research, we used a intensity band scoring from 0 to 6, where anything from 1 to 6 was defined as positive and 0 was negative. But these captures some of the data about how these kits are performing or how our sample sets, what the intensity of antibodies could be in them. So our study evaluates overall 2 ELISAs and 10 LFAs. But I would like to say there are other assays out there that we didn't evaluate, like the high throughput chemiluminescent assays on the Abbott Architect or by Roche, which are coming out that you may be hearing of. Those reagents weren't necessarily available to us at the time we started this testing, but there is a lot of test performance data coming out on those that I recommend you look out for. In regard to our study design, we had samples available to us from 128 SARS-CoV-2 RT-PCR positive specimens, and those came from 79 symptomatic individuals. So you might notice there's more specimens than there are individuals, and that's because for some patients there was serial specimens available. And what we decided to do for those cases was pick 1 per patient per each 5-day time interval, which is sort of represented down here in the table. And this is to sort of capture that seroconversion data and seeing how antibody detection worked by time from symptom onset. We were able to assess specificity in pre-COVID 2019 blood donor specimens. We had 108 of those. And we also had 52 specimens that that were negative for SARS-CoV-2 by RT-PCR and or had additional respiratory pathogen multiplex PCR testing. Now this is the breakdown of a small breakdown of the numbers from our table. There's a more extensive table in the preprint. But one thing I'd like to note here is we did capture some data about the highest level of care. We did have a number of people from ambulatory admitted in ICU cases, but please note at the later time points, the ambulatory cases were not as available as you'd expect. Talking a little bit about our study design, I think this is important to really run through this. So because the LFAs are subjectively read by a reader, we really have to blind people to this. So we took our specimens and we were able to randomize them to 96 well plates. These were then subplated for each assay run to minimize freeze thaw. And when the LFAs were run, they were read by 2 blinded readers that scored them independent of each other. That data was then given to the data analysis team and was kept separate from the readers, so there was no bias, or to minimize bias, and there was a lot of data analysis and figure generation going on live time during the study. So going into our first result, I would like to say we're looking at the detection of SARS-CoV-2 antibodies by time from symptom onset. And to just sort of walk through this graph, on the y-axis here, we see the percent positive compared to the RT-PCR positive status. Each column here represents that days from symptom onset time interval. Each row represents whether the test was scored positive by either being IgG or IgM positive, or separated out by IgG and IgM separately. So what we're, and each individual dot and whisker here represents is one of the tests that we evaluated. And the whiskers here are the 95% confidence intervals. So what we see here overall is that there is a percent increase in positivity over time that really peaks in the greater than 16 to 20 and greater than 20-day regions. And this really fits with the kinetics that we saw from previous studies that are emerging. And this is a function of that seroconversion or antibody development. The next thing that we look at when you try to compare IgG and IgM is you see that IgM was really less consistent than IgG across the board for nearly all assays. And lastly, the highest detection rate, if your goal is to detect antibodies here, you combine the IgG and IgM components together. So if you had either or both, that was counted as a positive. And that way you collect people who are early on in infection, developing IgM, those who are later in infection in IgG, or those who are class switching. Next, here's a figure looking at our specificity evaluation in pre-COVID-19 blood donor plasma. And I'm just going to walk through this figure here a little bit. I think it captures a lot of data that's important to understanding how these tests are run. So each column here represents a test, and each row is a specimen. And where there's a little white gap, that's where a specimen was exhausted or unavailable. And each band here represents a lateral flow assay read. So that intensity score that was assigned by the reader. And each reader, there's 2 readers per column. So one band across means that it was the same score by each reader. And so what's being measured here is really the specificity, which is looking at those that are true negatives versus true negatives plus false positives. And we're assuming that these are all false positives because they were pre-COVID 2019. I would also like to note that we separate out the IgM and IgG components separately for tests that have it separate. There is one test that combines IgG and IgM. And the big thing that you take away when you look at this visualization is that the majority of false positive samples we saw were observed in the IgM component here, versus the IgG component. But really assay specific factors, like if there was but delving into that biology is a little deeper than this, but this is the score that was assigned. And overall, combining IgM and IgG results, we see that specificity across tests ranged from 84.3 to 100%. Though there was a fair amount of overlap in the 95% confidence intervals based off of our power. In regard to the limitations of our study, there was lower power for positive specimens from asymptomatic or convalescent cases here. We really only had a hospitalized population or those presenting an acute illness. And emerging evidence may suggest there are differences in antibody levels that may affect test performance. Lastly, we weren't able to do evaluation of different matrix effects. So for clinical validation, you would really want to look at serum and plasma separately. Even though there is a body of evidence out there that suggests they are pretty equivalent specimens, you still want to look at them separately for clinical evaluation. And we had no evaluation of whole blood or finger stick or capillary blood, which could be important for those point of care style tests that may utilize a lancet stick of the finger. As noted in the first slide, there is a great mobilization of effort that went into this project. And it was just amazing to get this done. So even though I'm the one presenting, I want to say that there was a ton of leadership on this project. I'd like to highlight my co-authors here who are underlined, as well as the Marston Laboratory and CoLabs who initiated this project, and also my co-mentor, Karen Byrne. There was just an outpouring of laboratory volunteers who were able to help get this testing done, as well as a lot of help from many other departments, either here or elsewhere. So I'm going to go ahead and end it there. Please let me know if you have any questions, and thank you for the time to present.
Great, thank you very much, Jeff. We do have questions. The first question that I'll relay is about the viral proteins that are used as the antigens in these assays. Are they all using the same viral protein, or are there different viral proteins? Is that part of the difference in what we're seeing here?
So that's a good question, and it's really hard to sort of unravel that in terms of what we studied. So first off, there is viral antigens that are used in these test kits. It's all included in our supplementary information if it was made available by the test manufacturers. So the two viral antigens that are used are the nucleocapsid protein, as well as the spike protein, or a component of the spike protein called the receptor binding domain. Some tests use one or the other, some tests use both. But when you're really trying to see if there's subtle differences between those antigens, what's wrapped into it is both the, is sort of the analytical variables of each test. So you'd really want to have sort of one test by one manufacturer that had, that was sort of produced under the same, produced in the same manner to really measure if there's differences by antibody detection, or differences of antibody detection by those different antigens. So I don't think we can really pull that from this data.
Great. We have another question about how many, if any, of the assays that were tested in your study have received an EUA, an emergency use authorization from the FDA, or I guess final approval.
So none of none of the tests that we evaluated actually had an EUA either at the time we were evaluating them. I don't believe any of them have them now. I think I checked in the last couple of days. The one that would that kind of falls into that category would be our in-house ELISA that was made by the sister laboratory, also in conjunction with the Manglik laboratory that produced the protein. So the in-house ELISA is a modified form of the Mount Sinai ELISA.
Great. We had another question about whether you considered using densitometry to assess the lateral flow assays independent, in addition to the subjective evaluations. Do you think that would have added anything?
I definitely think it would have added things, and it's it all kind of goes into the regulatory aspects of QC control. However, that was discussed early on, and we wanted to generate real-world test performance data. So the way that these tests are really designed to operate is by a subjective reader in a point-of-care style. And so that's what we really wanted to capture in our data analysis. I don't think that precludes doing even comparative studies kind of going forward to looking at reader scores versus densitometry. But I think really there's so many different types of ways to do image analysis or densitometry, and analyzing those will be, or picking the right one will be difficult, especially if there has to be standardized conditions or where you may have to read these tests, whether it's sort of, outside in the clinic or in a very controlled laboratory setting.
Great. One more question I see, which is, how were the pre-COVID-19 samples defined, and at what date can one be confident that there was no COVID-19 present in the community?
That's a good question. So the pre-COVID 2019 samples were from blood donors who at latest donated in June 2019. We feel that that's far enough back that it predates COVID, and that's how we defined our pre-COVID specimens. There was a range of specimens among those blood donors. The specimens go back to up to 2006. But they were only frozen one time at the initial time of collection, and freeze-thawed once before when we evaluated them previously.
Great. Maybe I'll squeeze in one last question from Michael Stryker. Were you surprised that the ELISA findings seem no more specific than the lateral flow assays?
It's hard to say. That's a little bit generalized in that some lateral flow assays had very high specificity, as well as some of the ELISAs as well. I would say it's good to see that there is we saw comparable performance across the board. You wouldn't want really tests to be disproportionately working. And so I think that was a really good finding, that you can see some of the comparableness of two different test modality formats, which could really be helpful depending on where you want to bring that test in and how that may work into a testing algorithm, if that's devised to have utility or if it's found to have utility.
Great. Well, thank you, Jeff. That was a terrific presentation. I think many of us saw that this study received quite a lot of publicity, including prominent publicity in the New York Times. And so I think you've already, even before this has gotten through peer review, succeeded in raising a lot of consciousness about this as an issue. And hopefully the FDA and others who are thinking about how to interpret these kind of tests will take this into account as we begin to implement public policy. Our final presentation comes from Monica McLemore, who's an associate professor in the Family Healthcare Nursing Department, also an affiliated scientist with the Advancing New Standard in Reproductive Health program and a member of the Bixby Center for Global Reproductive Health. And she's going to tell us about Pregnancy Coronavirus Outcomes Registry, or the Priority Project, and the Reproductive Health Equity and Birth Justice Corps. Monica?
Thank you so much for having me. It's really exciting to be here. I know many people who were on the university-wide town halls last week had a chance to hear from Dean Gillis. So it's really exciting to be with all of you the day after what would have been the 200th anniversary of Florence Nightingale's birthday. So I'm glad that you're hearing from the School of Nursing, and I want to shout out our Associate Dean for Research, Dr. Julian Johnson, for having me. I'm very excited to tell you about the community engagement core that we are adding to the current pregnancy registry study entitled Priority. And I would like to shout out the innovative and bold thinkers who really pulled this study together very, very quickly, including IRB, to launch in probably about 10 days. And we've been enrolling people for about 7 weeks. So by name from the OBGYN department, Dr. Vanessa Jacoby. We have Stephanie Gaw. From UCLA, our collaborator, Yalda Afshar, and Valerie Flarman from the Department of Pediatrics. For people who don't know, the Priority Study is the Pregnancy Corona Outcomes Registry. And as we know from many other outbreaks and pandemics, whether it's H1N1, SARS, Zika, MERS, swine flu, that we see a different manifestation of illness and disease trajectory for pregnant people. And one of the things that we know already is that we see in past outbreaks more severe illness, hospitalization, we see miscarriage, preterm birth, and we have seen infant and fetal outcomes specific to babies born with birth defects. And we know currently there's almost no information in the published literature available about COVID-19 and pregnancy. Currently, the study has been up and running. We've been enrolling people since March 22nd, which is about 7 weeks. Eligibility, you can see here on the screen. Patients receive questionnaires and reminders every week for 4 weeks during pregnancy, and then they receive surveys postpartum, and then up to 12 months after the birth. We're collecting everything from demographic information to health history, to household exposure and course of disease. We also will have medical record data that will allow us to understand hospitalizations, lab values, birth outcomes, and any treatments that were received. As of May 11th at 1:40 p.m., we are churning out these data. You can see the recruitment thus far. This is both a self-referred study, as well as clinicians and healthcare providers can actually refer people to the study. You can see that we've had about 665 people self-enroll, or total self-enrolled, excuse me, and we're enrolling approximately 20 people per day. And it's been super exciting to sort of watch the excitement about the study and to be able to sort of see the response of people who have been enrolled. I'd like to make a specific observation that the low numbers of hospitalized individuals is actually a unique strength of this registry, because we are seeing the fact that we're not exclusively focused on the inpatient course of the disease, particularly when we know that some people may be at home and feeling sick. And one of the things that you know, it's been easy to know that we can get medical record data, but it's also quite curious for us to know that we have people in community who are currently pregnant, who are COVID positive, or persons under investigation for COVID, so that will give us some outpatient data and repeated measures over time. You can see that by region, there are some real gaps in where we see representation. I also think it's super important to note that, you know, the demographics of the study as we currently look at individuals enrolled are not necessarily representative of and do not necessarily match the demographics of the people who we know will shoulder the greatest burden of COVID-19. Many of the people who enrolled early on in the study were doctors and nurses and other healthcare workers who were pregnant at the time of COVID and were exposed because of their occupational work. And so we have a great bit of work to do specific to understanding regions of the United States, as well as the age, race, ethnicity, sexual orientation, and gender identity of individuals enrolled. So that's where me and my team come in. We're super excited to launch the Reproductive Health Equity and Birth Justice Core. And this is who we are as a team. We have partnered with the Black Women's Health and Livelihood Initiative, which is in the OBGYN department, led by Andrea Jackson and Judy Young. And then from OBGYN, as well as Epi and Biostats, as well as the School of Nursing, we've really pulled together some existing projects that we're all working on to really be able to leverage our professional and personal relationships to ensure that we can bring forward the level of age, race, ethnicity, sexual orientation, gender identity, as well as other types of diverse income, and with a real focus on Black, Indigenous, people of color, who will experience the greatest burdens of COVID-19. We also think it's super, super important to also sort of point out that our work is really, really specific, not only around recruitment, but also retention of participants while they are in the study. We also plan to launch a national community advisory board that will have oversight for the study. And we seek to deploy, and hopefully if our IRB is approved this week, we'll launch next week in 6 geographies, a protocol that will allow for community members and community-based organizations to provide any questions that they have around healthcare, around research, around policy that can be answered from the registry. And we will be adding questions to really look at the impact of racism and poverty and those individuals who experience the greatest burden of COVID-19, to add some questions to the study so that we can look at those questions over time and be able to have the opportunity to know what research and policy and healthcare questions are most important to them that they would like to see added to the registry. The geographies, these are the incredible maps that come out of Johns Hopkins University. This is from last Friday, so I didn't pull today's updated map, so this could look different. But for those of you who are familiar with these heat maps, to know where the hot spots in terms of COVID testing and COVID deaths are, these are the geographies where we will be working. So we will be partnering with community-based organizations and collaborators, Black women-led, Indigenous-led, and people of color-led organizations, Chicago, St. Louis, Illinois, Detroit, Michigan, in the New York, New Jersey, Pennsylvania, DC, Boston areas, as well as in Atlanta, Georgia, Louisiana, also looking at parts of Texas. And we have some work that we'll be doing in California because, of course, we're here and we have collaborators and partners here as well. You see the big hot spot in Arizona and New Mexico. My team and I already had pre-COVID work that we would be doing in that geography. So we've decided to pivot and include COVID-related questions within the work that we had working to help their perinatal equity initiatives on the ground working with Black and Indigenous individuals in New Mexico and Arizona. So we're hoping to get a broader level of community engagement across the country, in addition to recruiting for individuals to join the study. And to have people who are Black, Indigenous, people of color, queer folks, sexual orientation and gender minorities, and gender nonconforming and non-binary people really enroll in the study, and to know that they have capacity to be able to do so. Our team is going to be active doing tweet chats, other webinars with community-based organizations and organizations that serve Black, Indigenous, people of color, patients who potentially could enroll. And so you'll see more and more of us really trying to get folks to the priority.ucsf.edu website, because we think it's super important that the registry be representative of the communities that bear the greatest burden of COVID-19. I thank you in advance for just listening to us, and I hope if you're looking for other nursing faculty, we have several that could speak to really great topics, and I look forward to whatever questions that the audience currently has about the Reproductive Health Equity Birth Justice Core to the Priority COVID-19 Registry Study for Pregnant People. Thank you.
Thank you, Monica. That's great to hear about. I guess I'd like to start out by asking what you've learned from your previous work are really valuable ways to engage communities that may traditionally not be well represented, either because we're not making an adequate effort to represent them, or because they have concerns about what participating in research might mean.
I completely appreciate the question. It's one of the reasons why we're partnering with and trying to get financial resources to our community-based organization partners. You know, community-based organizations, specifically, you know, Black, Indigenous, and people of color-led organizations, they have the trust of community members. And so as we provide them, you know, culturally, linguistically, you know, racially and ethnically appropriate materials that explain the study, and to help people understand that they can have the questions that are important to them also be added, that builds trust between not only the community-based partner, but also our research team. And so that's why we're working specifically, not for us to take the lead and to jump in the community and say, hey, we want to hear from you, but to work in partnership with those existing organizations that have those relationships already, to then say, hey, here's your opportunity to include some questions. What do you want to know about COVID-19 that we potentially could answer from the registry? That's how we are approaching it. And we found that historically, that's been the best and most efficient way to be able to ensure not only community voice, but that we get the levels of participation that we're seeking.
And do you have a way that you structure being able to get back to communities and tell them what you've learned?
Absolutely. And for us, retention is just as important as recruitment. So we actually check in with individuals when it's time for their next survey. We make sure that they receive, you know, notification from the organizations that they trust. That's why we have a logo. That's why we have swag. That's why we're going to be on Twitter and Facebook and Instagram, making sure that people can hear about the study in real time as data move forward, just so that we also can amplify the kinds of questions that people want to be able to ask. The reason we want a national advisory board is because there may be regional differences in terms of questions that might be relevant in Texas, but might not necessarily be relevant in Washington, D.C. And we want to be able to support those different regional nuances and be able to get back to people in real time, not in slow, you know, high impact peer-reviewed journals, but also really being with community in using the communication tools that they use. And for most part, for many Black, Indigenous, and people of color and queer folks, they use a lot of social media and they use a lot of phone technology, not necessarily computers and Zoom.
Great. Thank you. That was a really useful presentation. We're very glad to have the opportunity to acknowledge nurses in the School of Nursing. Understandably, nurses have gotten a lot of attention in their role at the front lines in the clinical response to COVID. And I think it's important to point out that nurses in general, and in particular at the UCSF School of Nursing, have a real important role to play in research. I think there's a nice connection between the three talks we heard today. I think you heard a lot of elements in the first talk that were echoed in the final talk about the importance of working with the community. I think we heard obviously a lot of important concerns about how these studies are done. The serology is, the way you do the serology is important. It's not enough just to do the test. You got to do the right test. So I want to be respectful of people's time. Thanks to everybody for participating. Thanks to the audience for good questions. As I said before, for those of you who missed part of this, it will be available online for download shortly. We'll try to answer all the questions that we weren't able to answer during the town hall. And on behalf of Lindsey Criswell and the Office of Research, I'd like to thank you for your attendance. And please stay tuned for announcements by email and on the website about future events. Everybody take care and be safe, and thanks for coming.